This next part of the program is a very exciting part. It's a unique part of the program. We've talked about how the IMF is international, and we've talked about how in addition to providing supportive care and knowledge is power for patients, that we also do research. And so we're really pleased that out of his busy schedule, Professor Sigurdur Kristinsson from the University of Iceland is here to give his presentation about a very fantastic and interesting project called iStopMM, Iceland Screens Treats or Prevents Multiple Myeloma. And so it raises a whole lot of new and exciting possibilities of how we approach the management of early disease as it leads into myeloma. And so this is what I think is a glimpse of the future. This is the way that we're going to be looking at the approach to these diseases 5 and 10 years from now. And so to introduce this, we have created a video. This iStopMM project has been running for 5 years now, since 2017. And so both Sigurdur and myself were very excited that this was getting up and running. And so we created a video, and we're going to start by showing this short video before Sigurdur presents. And so if we could load that video, please.
iStopMM study is Iceland Screens Treats or Prevents Multiple Myeloma, and the whole idea is early detection can lead to early treatment and therefore prolonged survival, improved quality of life, and hopefully cure. We invited all Icelanders 40 years and older to participate in the study. This is the third year, and we have very good participation rate of over 80,000 people, and now we have almost 50,000 samples in-house that we have analyzed. Those that are diagnosed with MGUS or smoldering will enter a randomized clinical trial with 3 different arms with different approaches with regards to workup and follow-up strategy.
Without a doubt, this is the largest and most ambitious study in the area of myeloma and plasma cell disorders. And the interest for the Black Swan Research Initiative is that early diagnosis can lead to the possibility of early treatment, early intervention, and to potentially be able to cure myeloma. Because it is nationwide, the conclusions that you can draw are much more decisive and much more important. What are the features that would indicate the progression from MGUS to smoldering to myeloma? For a whole nation, it's just incredible.
Nice to meet you. People here in Iceland understood that it was our duty to help science in this way. Your organization is a testimony to the fact that we can and should and must use all means to advance in the fields of science. Just like me.
People of Iceland really show a willingness to help others to go into these trials and research programs because they know that it's going to open up the door to the cure. And that's our ultimate goal always, is to find a way to a cure.
I'm very proud of it, really. And for us here, I think it's a natural thing to, at least from my perspective, is to participate in such research.
It's very important for us all, so I think it's our duty to do it. So I feel very happy about that.
despite all these screening programs in the world, there is very little research on the psychological impact of being screened. From the very beginning, this has not just been a very narrow research-minded project, but it has always been built on the idea that this is being done for the patients. And I think that's one of the reasons why so many Icelanders signed on to the study, that they realized that this was really being done to take really major steps towards treating myeloma.
Since we opened the clinical site last year in April, we have met 1,200 participants for the first visit.
And we do blood tests from everyone, and for most of them we take some bone marrow tests as well, and then we do some physical examination.
For the screening to be useful, it needs to be practical and manageable, and so you do need a bone marrow for the initial diagnosis, but subsequent to that, it's now feasible to use blood testing to monitor what is the status of the MGUS. Is it remaining stable? What is the status of the smoldering myeloma? Even the myeloma with treatment can be monitored and followed using blood testing.
The prevalence of smoldering myeloma is higher than we anticipated, so that could have some implications throughout the world, because treating early at the smoldering phase is beneficial. You don't find people with smoldering myeloma because they are asymptomatic unless you screen for them or if you find them by chance. And we don't believe in a chance here. We want to go out there and find them and offer them early treatment.
The 80,000 and more individuals who are participating have genetic information available. They have been sequenced, and this genetic information can tell us if there are underlying genetic variants in patients with plasma cell disorders that are not present in the rest of the Icelandic population. And it will be possible to develop a risk model of genetic features that predispose people to get MGUS and myeloma.
As a patient, this research is critical for patients going down the road further. Just sitting through the meetings here and the latest on the iStop program is very exciting, and the opportunity for us to bring that information back to support groups is unbelievable.
When you gather so much information, blood samples, results from the hospitals, all cancers, every prescription that they have gotten, you see that the complexity of the study becomes more and more. But also you see so many opportunities on what can be done. So every time we sit down and talk about new ideas on what to do, we come up with 10 or 20 new ideas. So what we're doing now is, besides what we decided at onset, we're also looking at other important areas like comorbidity, like neuropathy, like cardiac disease, renal disease, and so on. So the opportunities are actually endless.
So we hope that you enjoyed that video. I think it does give you an introduction to Iceland, an introduction to this project, and an introduction to Sigurdur, whom I welcome up to the podium now to discuss where are we. That was early after the launch when these patients had come in to the study, and it's become such an active and an important study. So please welcome Sigurdur.
Thank you. Thank you very much, Brian, and thank you everyone for having me here in beautiful Florida. I just arrived last night, and I am looking forward to spend this day with you. And the taxi driver told me I have to go visit the beaches here, so I might have a look later or maybe tomorrow morning. But I'm not here to talk about that. I'm here to talk about the iStopMM project. So let's start. So basically, I will just go over why we
launched this study and what's the purpose of the study. And then I will tell you the findings that we have so far and a little bit about a glimpse into the future, what we might expect. So basically what we're doing here is, this is this point, yeah. So we have the B cells that when they meet like a virus or something that enters the body, they start producing antibodies. For some reason in MGUS and myeloma, these plasma cells, they start to produce proteins that are not beneficial but can actually be harmful. And you have this way here going from healthy plasma cells to the precursor plasma cells where you have MGUS or smoldering myeloma, then it can develop all the way to have multiple myeloma. So basically what we are doing in Iceland is we want to screen and identify individuals at this phase to try and prevent them from going to this place here, myeloma. So this is just a picture of the protein electrophoresis. You might be familiar with it, but this is basically a protein electrophoresis where we're looking for an M protein or M spike. Here are 3 individuals, and you can see here the difference between these 3 is this one here has a lot of bluish color here. So the lab will tell us that we suspect that this individual might have an M spike, so they might have something to do with myeloma. And then we go on and have a look here in the lab to see what kind of an M spike is this here. And we screen if they have IgG, IgA, or IgM. And this particular individual has IgG. And then you can see the light chains called kappa and lambda, and this one has kappa. So this individual has an IgG kappa M spike, and then they will tell us the concentration of it, and it might be, 0.5 grams per deciliter or whatever. So this is basically what we're doing for everyone in Iceland. And this is just a short reminder about what is MGUS, the precursor to myeloma. So you have an M spike, this M protein on the protein electrophoresis. You have no underlying lymphoma or myeloma or any disease. You're basically just healthy. It's quite common. It's 4% in individuals 50 years and older, and I will show you the prevalence in Iceland. The important thing is about 1 to 1.5% of these individuals with MGUS, the precursor, will develop myeloma per year. So all myeloma patients, they have had MGUS before they get myeloma, but it's usually not diagnosed. And absolutely not everyone with MGUS develops myeloma. So I don't need to go into any details here. It's just to remind you that we are talking about 2 precursor conditions called MGUS, where you have low count of these plasma cells in the bone marrow, and typically you have a low concentration of the M protein or M spike in blood. Here you have the smoldering myeloma, which is a more advanced precursor. It's still not myeloma. And here you usually have more than 10% plasma cells in your bone marrow. And then you have myeloma here. So we're looking at this progression here. So this is the typical picture that is often shown. These are individuals with MGUS, and if you follow individuals with MGUS over time, you can see here that in 10 years' time, about 10% of them have developed myeloma. So 1% per year. However, if we look at the smoldering myeloma people, you can see that the risk of going from smoldering myeloma to myeloma, it goes up here. So after 5 years, about half of them have already developed myeloma. So these are the individuals that we want to capture and treat and prevent them from having myeloma. So we looked at this in Sweden some years ago. High-risk smoldering myeloma that are typically not treated. They are followed. And we do what is called watch and wait. And people or patients usually call it wait and worry. So let's see here again. So you can see here that if we have high-risk smoldering myeloma, and these are all individuals diagnosed in the whole country of Sweden, after 1.5 years, you can see here, 18 months, half of them had developed myeloma. So these are just being followed, and then, oops, you have myeloma, then let's treat you. So we think that it makes sense to treat them here so they do not develop myeloma. And it doesn't only make sense, there are also studies that have shown that this is actually beneficial. So there are 2 great studies out there, one from 2013 and one from 2020, where they have randomized, and either you get treatment for your smoldering myeloma or you don't get treatment at all. And then just compare the 2 arms, what happens over time. And both studies show the same thing. You delay the progression from the smoldering myeloma, the precursor, to active myeloma. So you should treat early and not wait for them to develop renal disease, anemia, bone disease, and so on. So this is how we approach smoldering myeloma in Iceland. I don't think we need to go into any details about that. The important thing, though, is that survival in myeloma has revolutionized and has dramatically improved in recent years. You can see here, this is also a study that we did in Sweden. You can see here, if you look at women, that is like a woman that is 55 years old in Sweden, 1973, her survival is quite low because we didn't have a lot of therapy. And you can see here that the curve goes up and up and up, and here's like a break in the curve, so it goes even faster up. And this is in 2013 or 14, so this is even better now. When we have this curve up to 1.0, that means there is no difference in survival whether you have myeloma or not. That means we have cured myeloma. So this is what we want, where we want to go. So why has survival improved so much in myeloma? Well, we have great new drugs. We are getting better at prognostic factors, supportive care, and so on. But also, we think that we are treating the disease earlier. We are following individuals and we are capturing them, and we are treating earlier before they become too sick. So we asked ourselves some years ago, does follow-up for MCUS matter? Do we need to follow these individuals that have precursor disease every year or every other year, or shouldn't we do it? So we did a study, also based on Swedish data, where we looked at survival differences. You had myeloma individuals that had been diagnosed with MCUS before, they had the precursor, they were being followed, and then they got myeloma. And then we compared it to individuals that had myeloma and no one knew they had MCUS before. They just came to the clinic, had full-blown disease. And you could see there that the difference in outcome was actually better if you had been diagnosed with the precursor. So that means that follow-up for MCUS is important. You should follow these individuals for progression. The problem there, though, is that almost none of the myeloma patients that we diagnose has actually been diagnosed at the precursor level. So about 5% of myeloma individuals have been captured at the MCUS level or the smoldering level. So early intervention really isn't, is only a theoretical option in practice. So this is what we discussed in this famous video that Brian just showed us. How do we find asymptomatic people, smoldering myeloma patients, that we want to treat early? So either by chance or by screening. And as I said in the video, we still don't believe in chance in Iceland. So we wanted to see, should we screen for MCUS? It makes sense, there is some data there, but you need to really do a randomized study to answer this question. You cannot just start screening everyone in the world for myeloma without doing the actual study. So this is why we screen for breast cancer, we screen for cervical cancer, because this kind of studies have been conducted. They have shown that it leads to an improvement in survival and other outcome measures. So we are trying to answer that question in Iceland. Should we screen for MCUS? So here's the story behind the scenes. So we did the study which I showed you that survival was better if you had been diagnosed with a precursor. So I was invited to a meeting in Edinburgh in April 2015 and discussed this finding I had. I gave a talk, I think it was the last talk of the meeting, and this is one of the slides I showed. This is April 2015, and I said, there were some critics there saying that, well, this doesn't apply to a screened population, and MGUS is just diagnosed because you have something unrelated. And then I said, well, I'm the young boy here. I have more gray hair now than I had then. But then I said, okay, let's see what the screened population looks like. So this is an actual slide also from this presentation I asked, just like the very last slide was, should we screen for MGUS? And then I said, thank you, 2 questions, and then I sat down. Then there was dinner, and then we had a continued discussion about this thing, screening, and some people were saying, yes, we should screen, and other ones were saying, no, we should never screen, and we were sort of in between, and we said, maybe we should do the study in Iceland. What if we can get like 50,000 people or 30,000 people to join the study? Should we do it? So I went home, and I was thinking about this constantly. We should try and screen all Icelanders for MGUS. So time goes by, and I am invited to the Black Swan Research Initiative meeting at AS later this year. This is December. And then Brian Jury was there. I took a sneak photo of him, as I usually do. And he was talking, and I prepared this sentence I wasn't paying attention to anything he was saying. I was just thinking about, I have to pitch my idea. He has to love this idea. So I practiced this sentence in my head. And then finally, when the meeting was over, I got like a moment. It's like when you meet a celebrity and you have to say the right thing. So I said, hello, Brian. My name is Sigurdur. I'm a hematologist from Iceland. We want to screen Icelanders for MGUS and prevent myeloma in Iceland. And then there was the golden sentence that I think was the thing that he liked. Is that within the scope of the Black Swan Research Initiative? And I could see in his face, he was like, immediately he got the idea. I love it, he said. And then he said, where's Lisa? Where is Lisa? And then he asked Lisa to join, and I was supposed to send out a proposal for this project, and then things happened very, very fast. And it was approved by the IMF and the Black Swan Research Initiative, and here we are a few years later. So this is actually what it looked like back then. I was not very good at presenting things, and PowerPoint was super ugly at the time. That's why it's like blue and with all these shades and stuff. So this is the original design. And this is the actual Icelandic name for this. Skimun fyrir góðkynja einstofna mótefna bæklun lýðgrundu klínísk rannsókn. So what happened then is we had the scientific design, and then we also had to have we have to sell it. We have to get Icelanders on board. So I stopped being a scientist for a few weeks, trying to come up with logos. So we were trying to say, okay, what kind of logo do we need? We want something that captures it, and it should myeloma, and there's all these M proteins and antibodies, and the people helping us, yes, it should be red because it's a blood disease. And then it turned out that people really didn't like the red color. So we had this is like stop myeloma. And then there's the blood here, and we tried all different kinds, and I was like, no. So we had this would have been awful, I think. So we had all these kinds of, these are the Iceland, and this is finally what we decided. So this is sort of I like it a lot. This is like the stop sign here. These are the Icelandic people, and they sort of look like antibodies as well. And then Brian came up with the iStopMM name, which I think is very helpful. Then I had to go and tell all Icelanders about this, because they want an intensive campaign. Everyone in Iceland should talk about this for a few weeks and and give informed consent and sign. So then you have to do all kinds of stuff. So I had to go to like meet construction workers, put on this helmet. I had to go dancing with the elderly in a remote town. I had to do all kinds of stuff. And Sigurdur, who is here hidden in a tent, he had to go to the east coast of Iceland to convince them to join. So he was like literally sleeping by the highway in Iceland here for a night, driving, telling Icelanders about the study. We also got our 5 minutes of fame, where we were interviewed by CNN. Sanjay Gupta came to Iceland and met with Brian and me, and that got me into a lot of problems. I can tell you about that later. But so locally in Iceland, it got me into problems, but I think outside of Iceland, it worked pretty well. So this is what it looks like now. So we have here all Icelanders here. We sent for protein electrophoresis and light change, free kappa and free lambda. Those that have an abnormal finding, they are determined to have MCUS, and then they enter these 3 different arms. This is supposed to reflect the reality today. We don't do anything about it, just people have it and we don't look for it. This is the chance group, and these are the 2 screening groups here. So the overall aim is to see, should we screen for myeloma and its precursors? Then there's lots of other aims, but the overall theme is early detection and early intervention. Screen, detect it early, intervene early, treat early. So how did we do it? We sent out a purple envelope to all Icelanders that were born 1975, that were 40 years old at the time. Everyone got a purple envelope, and this was also part of the marketing strategy. Have you gotten the purple envelope was like the thing we were saying. And then I told people that they should just go online to mgas.is, takes 27 seconds, give informed consent. And then it just happened like over a few weeks that Icelanders they were loving it. They just gave informed consent. I will tell you about that here. So Iceland is not a very big country. There's only 350,000 Icelanders living there, but there are 35 laboratories throughout Iceland. So we contacted every single one of them. We said, a lot of Icelanders want to give us blood. We cannot take all these blood measurements ourselves. So they are going to be coming to your clinic for various reasons. They have their gallbladder disease and cholesterol or whatever. So when they get their blood drawn, we want an extra serum sample for our study. So that worked very well. Then we did this here. I think we can go over to this. So we invited about 148,000 people. 80,759 gave written informed consent and joined the study. And we have since then screened 75,000 individuals. So thanks. Yeah, this actually blew our mind. This is absolutely phenomenal. And what is also interesting is because Iceland has a centralized health system, so every diagnosis that is made from general practitioner to the hospital, private clinics, every blood sample analyzed, every cancer being diagnosed, this is all centrally registered. So for every one of these 80,000 people, we get every single thing that the medical healthcare system knows about them from the past, and we update this twice a year. So these are just examples of the data we have. We have like 8 million primary care visits with all these diagnoses of diabetes and hypertension. We know a lot about these individuals. Prescriptions, 17 million prescriptions for all these medications. We can see, is MCUS associated with use of some drugs? Does that delay progression or and so on? But also an important part here is the psychological aspect or mental health, because if you screen individuals and you give a diagnosis of a precursor to cancer to 4 or 5% of the population, we were worried that we might also cause harm. We would like cause anxiety and stuff like that. So we take that part also very seriously. So we are doing an intensive analysis of mental health of Icelanders. So basically, when you have these questionnaires and you ask people about it, I'm sure you have also received, questionnaires and emails, and you start like answering, and then you see, oh my God, I've spent like 3 minutes and it doesn't seem to end. How long is this? And at 5 minutes, people start dropping out. So we were thinking like, okay, maybe we'll get like 20, 30%. We had no idea. We had 70,000 emails. Icelanders use email a lot, so we could send questionnaires through email. So we were hoping for like 30 was realistic, 50% was our dream. And then you can see here, the purple is always, the iStopMM color. So we sent out these questionnaires, and we could see like just in 5 days, like Icelanders, yes, oh, there's a questionnaire, I want to respond to it. So they responded immediately. So we sent out a reminder to the people, and just in a few days, we had like 50% response rate. So we sent a second reminder, and now we sent out 3 reminders, and we have about 64% participation rate. And these are people that do not even have MGUS. They just normal people that signed up back in 2016, they just respond. And not only that, they spent 45 minutes. So my mother, she always calls me, oh, I got your email. And I was like, I'm not sending the email to 70,000 people, but I get it. And I responded, it's a bit long, and I was a bit worried, but I don't think it has anything to do with the study. It's like, fine. And then you can see here that people open the questionnaires, they actually finish also the questionnaires. So 90% of them, they go through and they spend their 30, 40, 50 minutes really responding to all our questionnaires. And these are the preliminary findings. So we are just comparing people that do not have MGUS before they signed up for the study and after they signed up. These are the people in arm 1, and these are the people in arm 2. So basically, on average, we are not causing harm by screening and letting people know they have MGUS. So 4.3% of Icelanders had an M spike, have MGUS, and you can see here that this increases with age. So the youngest population have about 1%, and then it goes up to like 14% in the very elderly. And we have like Icelanders, 100 years old, they signed up for a screening study for a precursor to cancer, no problems. And then we have some findings that I want to share with you. This study was published 3 weeks ago in a journal called Nature Medicine. And this is basically where we are analyzing for the first time the prevalence of smoldering myeloma. To analyze the prevalence of smoldering myeloma, you have to have a bone marrow evaluation. So you cannot do this without the bone marrow. And we sent out these, when we diagnose MGUS in Icelanders, they get an information letter. You have been diagnosed with this precursor. You have an appointment Wednesday at 10. We're going to do a bone marrow, blood test, urine test, and some questionnaires. 90% of the people, they just show up for the bone marrow. They have even never heard of what a bone marrow evaluation is. They're completely healthy. They just lie on at the bench, and we do bone marrow. So by doing that, and because of the generosity of the Icelandic population, we could identify and see that the prevalence of smoldering myeloma is very high. It's actually 0.5% of the population 40 years and older. And you can see also here that this goes up, the older you get. So prevalence, the smoldering myeloma is quite common. Also, what we have been analyzing is the free light chains. I'm sure that many of you are familiar with that, like you're trying to get the FLC or the free light chain ratio down because you want to get the response to your disease. It turns out that the reference values are not accurate, the published reference values. So without going into great details, you can see here the reference range here based on kidney function. So if you have a kidney disease, if your kidney function isn't normal, your kappa lambda or FLC ratio will be way off, and that's normal. So if you have a kidney disease and myeloma, and your physician is trying to treat you to a normal FLC ratio, they're probably trying too hard. The FLC ratio is normal about, as you can see here, whoops, the camera people are almost here. So normal reference range for this ratio, if you have kidney disease, is up to 3. So that's normal. Another thing is COVID. You know, we continued through COVID. We wanted to know if people with a precursor to myeloma had increased risk of getting COVID, and if they got COVID, did they have a serious COVID outcome? So we looked at this, and we had a very aggressive screening strategy for COVID in Iceland. Everyone was tested, you know, all the time. And basically, no, this is just the figure of it. Basically, MGUS is not at more risk of contracting COVID, and also the outcome is the same. So MGUS is not a risk factor for COVID at all. So here that is. What about the vaccination? So people are worried because, as I told you, plasma cells produce these antibodies. And vaccinations, they help the immune system to produce antibodies against these viruses like COVID. So people with myeloma have been worried that if I get the vaccination and trigger and activate my plasma cells, what will happen to my myeloma and my MGUS? Will my myeloma go through the roof and be activated, and I get like a relapse? So we have a lot of information. Everyone in Iceland, or more than 90% of the population, got vaccinated. We have repeated measurements of their M proteins over time, before vaccination, after first vaccination, after second, after the booster. So to make a long story short, it's not dangerous at all. It doesn't trigger your M spike to go up. So it's perfectly safe in individuals with an M spike to get vaccinated. So back to this the study. So the 3 arms I wanted just to show you here. This is one of the major findings from the iStopMM study. So the life as it is now, everywhere except in Iceland, is this arm here. This is where you don't screen, you don't look, you just don't know about it. And people, one day they turn up with myeloma or they don't. Then you don't capture a lot of the diseases they have. If you don't look, you won't find it. So if you look a little bit closer, like we do in arm 2, you will find quite a lot of these individuals with myeloma and smoldering myeloma, and some lymphomas as well. If we follow arm 3, where we do bone marrow in every single one, we do imaging or CD of the bones in every single one, we follow them closely, at least annually, some of them even closer. We have a lower threshold for repeated bone marrows, repeated imaging. We find a lot more. So if you screen, you will find more of these individuals, and you can offer them early intervention. So I think this is a very important early milestone for the iStopMM. So this is where we exclude the smoldering myeloma individuals, but it basically says the same thing. So the first milestone that we have was, is it feasible? Is it doable to screen? What will happen? Well, if you look for these diseases actively, you will find them. So you can detect them at the earlier phase. But we still haven't proven that screening is beneficial. We have to know about the quality of life, the negative effects like the ones I showed you, and also we have to look at the overall survival. Does it lead to an improvement in overall survival? So what we're also doing is offering early intervention. So we screen. And then if we have these individuals that have smoldering myeloma, we see they're like on the verge of going over to active myeloma, we say let's not make that let's not allow that to happen. Let's treat them early. So we have a clinical trial where we treat individuals with smoldering myeloma before they get myeloma. So we treat them with KRD, carfilzomib, lenalidomide, and dexamethasone when they have smoldering disease, and we treat them for 2 years, and then we are going to see what happens to the incidence of myeloma in Iceland. So if we screen everyone 2016, 17, 18, 19, offer treatment to everyone before they have myeloma, the incidence of myeloma should go down in the next 3, 4, 5 years. So this is what we're hoping to happen. If I have time for, So Decode Genetics, it was mentioned in the video, that's an amazing company that is working with us. So basically what they did, it has nothing to do with our study. Way before we started, they did what is called like a whole genome sequencing of the Icelandic population. So before we started, we knew that they knew to great depth the genetic profile of all Icelanders. Icelanders love to participate in studies, as I've told you, so everyone gave them their DNA. It's a private company, no worries. Just do what you have to do. And but not only that, they also know how everyone is related. So there's like a pedigree in Icelandic, I don't know the English word for it, but people that are interested in like pedigrees. So these have been like going through old church books, and we have a pretty good map how everyone in Iceland is related to one another. And I can go to like a homepage, which is basically called Book of Icelanders. I have it in my phone, so I go there, and I can just find the random Icelandic person and say, put in their name, and then I will get the pedigree. So I did that for this talk. So showing you here the very founder of Iceland, Ingólfur Arnarsson. He came to Iceland in 844, first one. He's like the first Icelander. And then you can see here how we are related. It goes through, 30-some generations here. They don't miss a single generation. They know exactly every ancestor from me to him. So this is very helpful when it comes to genetic studies. It's interesting for the pedigrees, but it's also interesting but then you can play around, you can look at like the president that Matt, Susie, and Brian, we are obviously related. So here you have me and him. Then it becomes more delicate. Here is my wife, Una. We are also related. So this is what can be done. And also what we are doing, we are using this for scientific purposes, obviously. So we can, if we know the people that have MGUS, we know their genetic profile, and we know the people that do not have MGUS, we can see if you are born with a tendency to develop MGUS and myeloma. So if you have some genetic markers already when you're born, you're at an increased risk of getting myeloma. So we are working on this, both to describe what are you at more risk of getting myeloma, and if you have these genetic markers, is your MGUS and myeloma is different than those people that do not have like the family version. So finally, since my topic was should we screen for MGUS, I think I've already said this. So although these findings are encouraging, the early detection, until final results of our study become available, which includes survival and quality of life, I think we should still advise against systematic screening and just be patient and wait for the final results to develop. So here are the main collaborators and of the iStopMM study, and obviously the IMF and the Black Swan Research Initiative are huge in that impact. And here is my fantastic team back home in Iceland that make all this happen. And with that, I'm happy to take questions, I guess. Thank you.
So, thanks to Sigurdur for just incredible presentation. This is truly an amazing project. The largest project where patients give their consent and they're randomized, over 80,000 patients. In our normal studies, we might have 300, 600. A really big study, we might have 1,500 patients. This is over 80,000 patients. It's just mind-boggling, and I do think over time it will change the way that we approach plasma cell diseases. If we're screening, and we talked about it earlier, these individuals will be tracked, and it helps to know ahead of time that someone has MGUS and might be predisposed to myeloma. So thank you, Sigurdur. If you want to have a seat here, you can put your coffee down and keep drinking, and we'll take questions. And if you guys want to come up, you might be able to comment on different aspects.
John, you want to start?
I don't know if you've met Dr. Peter Voorhees, yes, and Beth Feynman. So,
hello.
All right. So,
hi.
Oh, over there. Okay. Yes.
I would like first to apologize to the room because it seems that I always have a question, and apparently I do. I'm sorry. I was wondering, because all of this seems that has to do with multiple myeloma having a genetic component. However, in I think my case and in several cases, sometimes there's products like benzene used in sunscreens or other products used in like Roundup, which is something to kill plants or something like that, a herbicide, that can develop into multiple myeloma. So is this because we are already genetically predisposed, or is because there are some products that can actually alter your cells and develop a myeloma by itself?
Yeah.
Because you want to comment on, yeah.
Yeah, so thank you so much. This is an excellent question, and we always need people like you that ask the questions. It's not easy to ask questions, so we appreciate that, first of all. So second of all, this is part of what we are actually studying in Iceland. So what we do is we ask these individuals that gave informed consent, did you work at with diesel, did you work at this factory, did you do, so all these kinds of environmental factors. So we can use environmental factors like prior diseases, like autoimmune diseases, the genetic profile, and see exactly what you are alluding to, like what is the impact of being born with the tendency, and then you add an environmental factor and so on. So the short answer is we do not still know about the complexity of the interaction between all these effects. Usually when we diagnose people with myeloma, they have no known risk factor. They have no prior autoimmune disease. They haven't worked in like a factory that is known to cause cancer. Most people they have myeloma, and we don't think that it has to do with smoking or their diet or all these kinds of things. But this is what we are trying to understand.
Yeah. And it's difficult, because when you've been exposed to something environmentally, the disease may not manifest for many, many years beyond that exposure. So it may be hard to recall that exposure. And then it's important to recognize, as Sigurdur pointed out, this complex interplay between genetics and environmental factors. There are factors that can mutate and damage DNA, but genetically there may be people that are able to repair that damage better than others, for example. So it'll be fascinating to see what these guys come up with.
In cases, elsewhere around the world where there's been a link between some sort of a toxic exposure and myeloma, there is this lag time which is characteristic for myeloma, which could be 10, 20 years or longer, which does make it so difficult.
Right.
Okay. Other questions?
Right here.
Okay, me again. I'm not going to apologize. Luis Perez from Boca. I did a quick search and found that in the U.S., there's 160 million or so people over 40. If you use the numbers here, about 8 million of those may have MGUS. And the headline is, a recent publication in Nature showed that up to 8 million people in the United States could have the precursor to the second most common blood cancer. And it's really a question for the IMF in general. Congratulations on what you're doing in Iceland. It's jaw-dropping. And I'm here as a former reporter and as someone who has made a living promoting science and research. And I'm wondering why I'm not seeing this on the front pages of the New York Times, on the front pages of local papers. Why don't we have reporters at this conference? The IMF is doing great work.
Yeah.
Great stuff. Kudos.
All right.
But
Well,
the challenge is
we'll link you in with our PR, okay?
to go to that next level, because that's how you're going to get to the folks like me who I worked in this space and I didn't know. I knew multiple myeloma, but I didn't know anything. I had back pain.
Right.
And it was 10 months and the damage was done. And there are other people like me, and this science is going to change that, and it needs to be known not just with the people in this room, but beyond this room.
So I fully agree. I'll make a couple of comments and I'll turn it over to Sigurdur. But I mean, we obviously agree that this is going to be hugely important. I think that the one thing that we really agree on is that we want to be very, very sure. So for example, this point that Sigurdur has been emphasizing, we want to be able to be secure about the value of the screening. It's a randomized study, and the first thing that guy from the New York Times is going to want to know is, what showed up in the randomized study? Do you have evidence of benefit? On the other hand, we did take a chance, and we did have that interview with Sanjay Gupta from CNN right at the outset, and that did give us some high profile, and Sigurdur worked really hard. We all had lunch with the president of Iceland, so this is not like we're living under a rock. We are trying to make this visible, but in a careful and a prudent way.
Yeah, I totally agree. Thank you for this comment and a question. So there's a lot of excitement now about screening. So in the beginning, and when we did this video, we were super excited. And then just because we're doing the study, people have been like, everyone just wants to start screening because we are doing the screening study. So I am trying to be like their responsible scientist, saying, okay, we are doing this study to answer the question, should we screen or not? Until we have the results, we just have to wait and enjoy the uncertainty of it. And then when we know for sure, we will let everyone know. And then either we should screen, and then the rest of the world needs to start screening, or we shouldn't start screening, then we shouldn't. Yeah. So I think that's my take on this.
Yeah.
Right.
I mean, when you look at MGUS, the risk of it evolving into something that needs to be treated is about 1% per year. So there are going to be people, especially if they're diagnosed later in life, that are never going to require any intervention for this. So it is prudent to be careful and do the randomized study just as they're doing. But, they have a treasure trove of information, and they can, look at the genetics and, all the answers that they've gotten from their surveys, et cetera, to determine which of these MGUS patients do we need to worry about, and which are the ones perhaps that we don't need to worry about and are not going to go on to develop multiple myeloma in their lifetimes.
Right.
I mean, it's just amazing what they're going to be able to do with this data set.
Right. But the hard endpoint is the survival improved by this early diagnosis and the offering of these interventions? Now, we are, I think, pretty confident the answer to that question is going to be yes, but we don't want to prejudge it. Although we looking to hire a PR firm, but we think that this is going to be the way to go. So what do you estimate? I mean, in terms of the survival, what would be your best guess when we would be able to break the code on that? Where we would be able to say, really, it's sufficiently trended.
So we did, like, it's when we plan these studies, you do like a power analysis. It means how many people and how long time do you need to follow individuals, to be able to get an answer to the question so you feel secure. And when we did that, we anticipated that we needed 5 to 7 years of median follow-up.
Right.
So when everyone has been followed, half have been followed for 5 to 7 years. So I think we're probably 3 years from now, we will have the answer.
Okay. All right. So we'll have a lot of questions in the meantime.
Yes.
Well, but in the meantime, we can have lots of side stories about Simon in his tent going around to check on patients and things like that.
Yeah.
We can have a lot of interest stories in the meantime.
And the main thing, should we screen or not, is just one outcome. Then, while we're doing that, we have all these different things like the impact of environmental factors, the genetics, smoldering, kidney disease, COVID. We can answer a lot of questions, I think, when it comes to MGUS and progression and risk factors and everything. But the main thing, the main question is, we have to wait another 3 years probably.
But one point maybe you could comment on is that the outcome for patients with MGUS is not normal. I mean, obviously there's 1%, 1 to 1.5% a year that develop myeloma, but for the ones that don't develop myeloma, their outcome is also not normal.
Right.
And so MGUS patients are susceptible to a variety of other things. And so you want to comment on that a little bit?
Yeah, so people with MGUS, they have low immunoglobulins compared to people that do not have MGUS. That means that they have an increased risk of infections. They also seem to have an increased risk of fractures and thrombosis and other types of comorbidity or other diseases. So it's not only the progression from the precursor to the cancer that's of importance, we think, but it's the other diseases that people are associated with MGUS. So screening might also, impact that as well.
Yeah, so that there are potential interventions related to those other problems, right?
That they're not chemotherapy for smoldering, but rather preventing infections, fractures, all these kinds of stuff.
Right. Number 3, okay.
Carol from Vero Beach. I have multiple myeloma, and my mother had a related disease, amyloidosis.
Right.
Correct? So obviously there was something in my DNA that caused my multiple myeloma, but you haven't mentioned that word, amyloidosis.
Yeah, so this is linked in, yeah.
So,
okay.
So the family history as a risk factor for getting myeloma. So if you have one relative that has myeloma or related disease like MGUS, Waldenström, amyloidosis, the risk of the first degree relatives is about twofold.
Yeah.
2 to 3-fold.
Yeah.
So if you have and that sounds like a lot, but if you have a very rare disease like myeloma, like amyloidosis, like Waldenström, even if you double the risk for your kids or your siblings, if you double the risk, the probability of them having the disease is extremely low. So 99 point something of people with MGUS, their relatives will never have any of that. But there are some genetic markers. Now they have 26 that have been described. So you're born with a tendency to develop myeloma-related disease, and there are markers in your DNA, 25 of them that have been described, that increase or decrease your risk. So you might or may not have that. It might be a chance. Sorry? Right, yeah. So probably that might have impacted to, the family disease in your case.
Right. No, I don't even want to comment on this. So in addition to the regular testing, patients are getting mass spectrometry of the protein, which can show if the protein is glycosylated or not. Do you have any information on that or not yet?
No.
Not yet. So that some of the features on the protein will tell you if there's a tendency for the protein to stick together, which is what causes amyloid. And so I guess that's going to be one more project for the future.
So we are screening. We screen for amyloidosis as well. So we ask about neuropathy. We ask about, we check protein in the urine. We do like special staining for that, and check the heart and stuff like that. But amyloidosis is extremely rare. So, but it's part of the project to look at these factors.
Right, and actually the Mayo Clinic is doing mass spec testing as routine clinical care now, and we have patients that we see in North Carolina who come to see us who've had that testing done at Mayo Clinic, and they'll have the glycosylated M spike, and then there's a comment underneath saying, please be aware that this may be associated with an increased risk of amyloidosis, and then there's another rare condition called cryoglobulinemia that's also associated with this glycosylation. So it allows us to put on our thinking caps and look really carefully at that patient to see if there's any signs or symptoms of those disorders.
Right. So I think ultimately that's going to be part of the commercial testing, where there'll be those kind of footnotes that will pop up. All right, so I see that we've reached the witching hour where lunch is ready, and I think we're ready for lunch. So thanks again, Sigurdur. Amazing work, and so glad that you came.